Are we on?
Yes.
Okay. Okay. Hi, good morning, everyone. My name is Lori Sadowski. I'm going to be talking to you about SBIRT, which is screening, brief intervention, and referral to treatments. Some of you may have heard about this before. For some of you, this might be a review. A large part of this training is really based on motivational interviewing. And I think, again, some of you may be familiar with that, and some of you, this may be something that you're just starting to learn about. So just to give you a little bit about myself, I was a patient navigator and then a care coordinator for 5 years at the Star Health Center in Brooklyn. And for the past 3 years, I've been training on SBIRT with residents, midwifery students, PA students, as well as community health centers, housing organizations, and peer organizations within New York City. Okay, so this is a very brief overview of what SBIRT is, and then if you're interested and you'd like, some more information, you could reach out to your local AETC and then schedule some more in-depth trainings. Okay, so what is SBIRT? So it is an intervention that's based on motivational interviewing, and the first part of it is screening. So with screening, we're talking about universal screening, asking every patient or every client that you see about alcohol, drugs, prescription drugs, and tobacco use. The brief intervention is really where you're using those motivational interviewing skills. So you're asking questions about pros and cons of substance use, barriers to making changes, supports or supportive people that could, support the person as they are making some changes. Then based on the brief intervention, if you feel like that person is ready to make some changes, that's when you would move on to referral to treatment. And we're going to talk a little bit more about that later, the different options that you have for referrals. Okay, so the goal of SBIRT is really to identify and intervene early for those who are at, I would say, mild, moderate, and high risk for psychosocial or healthcare problems that's related to their substance use. So by doing that universal screening, you're really ensuring that we're not missing anybody. And sometimes we feel like we know somebody, but sometimes things come up. Somebody may stop drinking for many years and then they lose a loved one or lose their job, lose their housing. Something happens that all of a sudden, maybe something that is a trigger for them to resume using again. So screening, this is a few key points about screening. So one is we want to always maintain that MI approach. We want to always, do screening that is MI consistent. And so for me, that means, asking permission. Is it all right if we talked about alcohol and drugs? And normalizing it. These are questions that I ask all of my patients. I ask these questions so that, I can better understand you. And also maybe, they're taking medications and you want to make sure that there's no drug-drug interactions or anything else like that. You want to make sure that the pre-screening and screening are really part of just general health and wellness. So it's not that this is something standalone, but this is something that's part of all of your other questions. And I know you have a lot of other questions and a lot of other surveys, but it's so important to know about alcohol and drugs because we know that it can impact so many other things. Work, school, family relationship. There could be legal outcomes. It could put someone's housing in jeopardy, their job in jeopardy, things like that. So we can't just skip those conversations. They're really important. And I'm sure many of you are already doing your own versions of screening for substance use. It could be using a validated tool, or it could be just having those conversations. It's just important that we're really asking those questions. So you want to ask for both alcohol and drugs, and you want to also make sure that we're asking about prescription drug use. We know that there has been a large increase in prescription opioid medication misuse and abuse. It's really important that we're asking our patients specifically about that. Also, any substance that there is a positive response in the screen, you want to follow up on. And if you see that there are any positive screens or kind of red flags to you, just follow up on it, ask some more questions. And again, we're always using those MI skills that we're going to talk a little bit more about later. And just keeping in mind that, we're not here to judge people. We're not here to make them do this or do that, but really just understand how does this substance fit into their life, what's good about it, what's not so good about it, what would they like to change, and how does that change really look like to them. So I mentioned there are a couple of validated screening tools. Many of you might be familiar already with the audit and the DAST, but there's also something called the TAPS. So this, what's nice with this is it gives you the option to screen for tobacco, alcohol, prescription meds, and other substances. So you're not limited. That is one of the issues with the audit and DAST. What's also nice is that it has you can actually do this online, and it will walk you through the questions and tell you, what the risk categories are for all these different topics and some steps to take. So if you haven't checked this out before, I definitely recommend, look up NIDA TAPS and, learn a little bit more about it. So one thing that I always think is really important, that make sure that your idea of one drink and the person you're talking to, their idea of one drink is the same. And part of that is just because we know that restaurants often give you more than, the 5 ounces of wine because that's what people want. And then, some bars or beer gardens, they'll actually offer 16 ounce, 24 ounce. So just going over that when you're doing a screening, one drink means that 5 ounces of wine, the 12 ounces of beer, and the 1.5 ounces of hard liquor. Okay, so going to move into the brief intervention. This is really where you're using those motivational interviewing skills. So many of you may already have had training on this. This is like I said, a brief overview of SBIRT and an even more brief overview of motivational interviewing. This could be multiple hours or even multiple day training on motivational interviewing. I'm just giving you a little taste of it so that if you've had those trainings before, it's a refresher, and if this is something new, you kind of get an idea of, what is motivational interviewing. So it's really about how we're approaching our patients, understanding, we're not coming from the point of power dynamics, we're here to tell them what to do, understanding that people are going to make change at the pace that seems appropriate for them in the ways that seem feasible for them. So a definition would be that this is a client or patient-centered directive method for enhancing intrinsic motivation to change by exploring and resolving ambivalence. So it's not that someone's difficult or challenging when they don't want to make a change. It's just understanding everyone has reasons for and against making change. So if you think about a change you might want to make, go to the gym, get to work on time, go to bed earlier, make some diet changes. Change is really hard. And so all of us, usually take some time to think about, why we want to make that change, and then kind of look into what are the barriers and supports for making that change before we move on. So I just want to point out this kind of shift with motivational interviewing. It's really we're hoping to move from feeling responsible for changing the patient's behavior, taking that on, that it's up to us, we have to do this, we have to do that, to understanding that change comes from within the person, and we're there to support them as they're thinking about the reasons and the means of actually making those behavior change. So MI is really about, it's a partnership, and we're focusing on, working together with the patient rather than kind of someone there that's, pushing someone along. Which is a good segue into talking about the spirit of motivational interviewing. If you've had some training before, you know that this is kind of just something that we keep in mind when we're doing MI. So it's not just about using those skills, the OR skills, but actually it's how we're approaching our patients. So the first one is it's collaborative. Like I said, this is a partnership. We're understanding that there are some power dynamics, but understanding that we're really trying to overcome those and make people feel like we are really working on this together, that this is not, me telling someone what to do and them going home and doing it, but asking the questions that get them to tell us what are the reasons they want to do this and how do they want that to work. It's also, that is what, evoking their motivation. So like I said, motivation for change really comes from the patient, not so much from what we're telling people. We're giving kind of like prompts or information that might get people thinking about what do I want to do? How do I want to do that? And we always want to be respectful of autonomy. So personal choice, we may not always agree with everything that the patients or clients are doing, but we're not here to judge people or to really explain like what our perspective is for coming at this from harm reduction. So maybe someone says, I don't want to stop using a certain substance. So maybe the conversation really needs to shift to talking about harm reduction, making sure they have access to needle exchange programs, making sure that if they're using an opioid, they have naloxone nearby, drinking with people that they feel safe with, that, if something happens, they will, get help or make sure they get home safely, things like that. And then always being compassionate. I'm sure each of you, went into this field because you are compassionate and you're passionate about what you're doing. It's just sometimes, when we do feel that we've had the same conversation over and over, sometimes it can be a little frustrating, but that's not our role there. Our role is to be a support, be a source of information, and make sure that our patients know that, we are there to do what is needed to help them to, make healthy decisions and get the resources that they need. Okay, so I hope that you are familiar with the stages of change. This is basically the key part of motivational interviewing when you're thinking about, talking to somebody as they're making a change. It's, where are they in this change process? So you want to know that because then you want to know how to respond to them. So basically, I think smoking is a great example for thinking about stages of change. You have somebody who's in pre-contemplation, they may say something like, I've been smoking for years and I'm not ready to quit. So they're really not at the point where they're thinking about change. They're, maybe they feel like they're either unwilling or they're unable to make that change, or they don't see it as a problem. It could be someone saying, marijuana is legal all around the country. Why do I need to cut down, or why do I need to stop using? Then you have contemplation. Somebody who's smoking may say, I know I should quit smoking because, it's bad for my health, but it's also something that helps me, get through the day. And so they're really more on the fence. They're in a very ambivalent stage. Someone who's in preparation is really figuring out, I want to make this change. I just don't know how yet. So at that point, you want to talk to somebody about the menu of options. There's, ask them if they've tried to quit before and understand that, there's a lot of options ahead of them, and figuring out what do they want to use? Is it patches or pills or support groups, things like that? Action, they're actually going to one of those options. So they've gone cold turkey, they're going to a support group, they're using patches or gum or some option. The maintenance is when they've really been doing this behavior change for 6 months or more. In the middle, we have relapse or maybe recurrence. Some other images may have recurrence. And so it's understanding that this can happen at any time and that people can kind of go to any stage. So it doesn't mean that somebody who is in action all of a sudden goes back to smoking automatically goes to pre-contemplation. They could jump right back to action. They could jump to preparation. It's our job to, in every stage, figure out where are they, what support do they need, and how do we kind of figure out, what's the next step. So I'm including this so you can see, again, how you respond. So pre-contemplation, somebody who's really saying, like, this isn't something I want to change, you don't want to be talking to them about the menu of options. You really want to be talking to them about, ask if they would like some information. Encourage them to ask you questions and, just work on that relationship. This is a time where you really want to be non-judgmental. You really want to be supportive. When someone's in contemplation, you want to ask, hey, what are those pros and cons about it? You're trying to help them to focus on the pros and to start thinking about what preparation might look like. And that's, again, where menu of options, figure out, have they tried to quit before or cut down before? What has worked? What has not worked? Action, like I said, this is where they're taking those steps, and we really want to focus on self-efficacy or confidence. We want people to leave the office feeling like, yes, I can do this, and I can keep doing this, and if needed, I can come in and I'm going to get the support that I need. And lastly is maintenance. We're really working on preventing the recurrence, and again, keeping people's confidence up. So I mentioned earlier the OR skills that are really kind of prominent in MI trainings. So these are open-ended questions is the first one, and this is where you're asking a broad question so that the patient can give you more information. So it might start with how, what, tell me about, and it's just meant to give the patient a little bit more time to speak. You have a lot of yes/no questions in the DAST audit TAPS. You want to make sure that you're giving them a chance to really open up, because if you keep asking yes/no questions, it might feel more like it's just an interview rather than a conversation, and that's what you want. When you're talking about substance use, you're really trying to have this non-judgmental, open conversation where people feel like they can really speak with you. So a question could be, how does drinking fit into your life? Or what are some reasons that you've thought about cutting down on smoking? Tell me about, what's happening in your life. And so it could be lots of different questions. Obviously, these questions could also apply to things like medications. Tell me how you take your medications, things like that. So as I mentioned, those closed-ended questions, those yes/no questions, they put people a little bit on the spot. I also, why questions? Some people feel comfortable asking them, some people don't. I think it's important to keep in mind that why questions with somebody who's maybe in that pre-contemplation or even contemplation stage really put people on the spot. And when people are pushed, they tend to push back. And also, if you thought of any change you want to make and people are kind of like, well, why didn't you just do it? Or why don't you just do it? We kind of are drawn to all the reasons, those barriers, all those things that are blocking us. So we don't want to put people in that spot. We want people to feel that confidence that they have the skills and the support to make changes. So those why questions can kind of put people on the spot. And they don't allow for people to explore that ambivalence. The next skill in ORS is affirmations. So this is where you're giving a compliment or a statement of appreciation. You're praising positive behaviors, or it could even be, somebody talking about making a change. It doesn't actually have to be that they're doing it yet, but that they're on that road to making changes. The reason we affirm is, again, we want to build self-efficacy. And just think of any time you've been given a compliment by somebody, you tend to respond, you'll explain a little bit about how it's been difficult or how you've been having an easy time with it. So it's just understanding that people respond well to affirmations because it's acknowledgement of the work that they're doing. If you're a parent, maybe you've heard things about, instead of praising children so much for the grade, praise all the hard work that went into it. And so it's the same thing. If someone comes in and they've, cut down from 10 cigarettes a day to 5 cigarettes, we know that was a difficult change. And so we want to acknowledge it. We don't want to let that moment go. And we don't want to let that opportunity to, let people kind of pat themselves on the back, give themselves some credit for what they're doing. Now, reflective listening, this is really the most difficult skill. It's something that takes time and it takes practice. So the reason that you want to do this reflective listening is you want to show that you're listening to your patient, but also that you've understood them. And sometimes when you do a reflection, maybe you're not accurate. Maybe you actually, maybe you didn't understand fully what they said. It gives them the opportunity to clarify and to continue to talk to you. Also, if you think of any kind of conversation that you have where someone asks you a question, you give them a response, and then they don't even respond to your response, they just kind of leave it. Sometimes we feel like, why are you asking me these questions? Is it you just want to kind of know for yourself, or you're here for me? And so by using these reflections, you can show, I'm listening to you, I'm trying to understand, and you're building on that relationship. I think, in now we're always texting people. So it's kind of like, imagine a friend always texts you a question, you write a long response, and then they just don't respond to you. It's that you're left hanging. And so by reflecting, you're showing, I'm here with you, I'm trying to understand, and let's kind of, understand each other a little bit more. So, like I said, if you go to a longer MI training, that's where you would see the different types of reflections. So obviously you have the simple reflections, complex reflections, which could be feelings or double-sided, reframing. So there's a lot of different options out there. So for example, a simple reflection, if someone says to you, I don't know why everyone's talking to me about my drinking. I don't really drink that much. A simple reflection would be, you're confused about why so many people in the clinic have talked to you about drinking. Or if somebody says that same statement, you could try a feeling reflection where you could say something like, you're frustrated that so many of us have talked to you about your drinking. So those are your simple, your complex. With substance use, a lot of times we find patients are in that pre-contemplation, contemplation stage. And so maybe you hear something more like, I know I should cut down on how much I'm drinking, but it really helps me after work. And so this is where you want a perfect chance to use double-sided reflections. So with this, you could say something like, on the one hand, drinking helps you after a rough day at work, and on the other, you feel like it's something that would be good to do, to cut down. So with the double-sided, you're always ending on the positive. So the reason that you're doing that is you really want the person to continue talking about the reasons that they feel it would be good to cut down. And there could be so many different reasons for that. So you're leaving it open for them to really tell you why, for their individual life, it would make sense to cut down or quit, or maybe it's even just using substances with different people, different settings, things like that. And the last part of ORS is summaries. So I'm sure you're already doing this quite a bit. You always want to end a visit summarizing what happened, what did you talk about, what are the goals for the next visit. And so it's just kind of focusing on what were those those reasons to kind of build up. So if someone said, they would like to quit smoking to save money, it would help, lower the number of fights they're having with a partner, something like that. So you want to kind of remind them about that. And also in that summary, you would also want to talk about maybe some things that they feel would be beneficial. So less fights would mean they'd have a stronger relationship. They could save money. They, it could be whatever, if it's for smoking, if it's for drinking or another substance use, just the positives that could come out of making that change. Okay, so speaking of change, the concepts of sustained talk and change talk are really the heart of motivational interviewing. This is about, it's not just about using the OR skills, it's using those OR skills so that people can make some changes. So in order to do that, we really need to understand what is the difference between sustained talk and change talk. So sustained talk, this is when somebody really wants to continue what they're doing. Somebody who says marijuana is legal, it's not a drug, it's not a big deal. They want to continue to smoke marijuana, or I don't drink that much, other people drink more, it's not a big deal. Something like that. So somebody is really saying, I want to continue the behaviors that I have. And so in this moment, that's when you really want to use those reflections, because we cannot argue with somebody to make them make the change that we feel. And sometimes those reflections is just acknowledging that somebody feels like marijuana is just a drug. It's legal. Marijuana is not a drug. It's legal in other places. It's okay. Whatever it is, we're just showing that we're hearing what they're saying. Because a lot of times when people give us sustained talk, we say something like, but you need to quit smoking, but you need to stop drinking so much, or something like that. But that's usually, again, that kind of like a closed-ended question. It can also put people on the spot. And it makes people feel like they need to cling maybe a little bit more to their current behaviors because they're feeling that they're being pushed in a direction that maybe they're not quite ready for. So sustained talk, it's a great time to use reflections. It's a great time to emphasize personal choice. You know, we cannot force people to make changes. That's not why we're there. We're there to make sure that people have all the information that they need to make informed decisions. And then their decisions, you know, we have to accept those decisions. Okay, and then change talk, the same way that we want to listen for sustained talk and learn to respond to it using reflections and emphasizing patient choice, we want to be listening for change talk. So if you've ever heard of this, the acronym for it is DARN CAT. So the desire, ability, reasons, need is kind of the mobilizing change talk. So people are starting to think about those changes. Commitment, activation, taking steps is really the commitment part of it. So they're at the point where they're going to move forward. So desire, it could be, you know, I wish I could stop drinking. I want to stop using cocaine, something like that. Ability, I could quit smoking if I wanted to, or I can quit smoking if I want to. Reasons, it might be, you know, fights with a significant other, financial issues. Like I said, there may be housing issues that are at risk, things like that. They might be saying these reasons. The need, someone could say, I need to quit smoking because I was diagnosed with COPD. So it's very specific, and they're saying, you know, this real need is there. So all of these are not actual steps, it's that they're thinking about it. So with those, you want to ask some more open-ended questions. You know, tell me more about what has you thinking about not smoking so much, things like that. We want to ask questions. We want to use those reflections again, and it might be affirming. You know, that's great that you're thinking about cutting down on how much you're using. And then we might have patients who are really more in that commitment stage. So they're saying, you know, I'm going to go to an AA meeting, or tomorrow I'm going to start using the patches, or this weekend I actually I didn't go out to the bar, instead I stayed home and, you know, did something in the house with friends. So they're really at the point of taking steps. And we want to always listen to this to use those open-ended questions and also to make those reflections. You may also feel like you want to elicit or evoke some change talk from somebody. So maybe somebody is in that, you know, contemplation stage and they're a little bit on the fence. So asking questions that kind of bring out those desires, ability, reasons, and needs. So something like, what has you thinking about making a change? Or if you were to change, how would you do it? Or what are some reasons for you to make a change? So you're asking questions that are going to get people to think. It doesn't mean that they're going to make that change today. It's that they're starting to think about it. And that's what we're really looking for. We're looking for those small steps. You know, we can't expect somebody to go from pre-contemplation to action in one visit, but we're understanding, you know, it is a slow process, the same way any change for us is a slow process. You could also kind of query extremes. So this would be, what would be the best thing that happened if you stopped smoking? What would be the worst thing that happened if you continue to use heroin? So you're asking someone to think beyond the day in, day out to what's the bigger picture. Same thing with look back. What was life like 5 years ago before you started using cocaine? What do you want life to look like 5 years from now? And then always we want to focus on goals and values. So you may have some patients who, you know, they're very focused on, I want an undetectable viral load. I want my A1C at this point. But a lot of times people really want their health. They want good health so that they can do something else. And that's what we want to, you know, really focus on. Do they want to go to school? Do they want to work? Do they need to be healthier and more, you know, physically active so that they could keep up with kids or grandkids? What's their real goals? You know, we're not just, it's not just about health, it's about so much more than that. And so understanding how substance use or other behaviors might get in the way of those goals is a really good way to get someone to start thinking about change. Again, doesn't mean they're going to walk out making those changes, but they're thinking about it. Okay, some of you may be familiar with the readiness ruler. This is a really good way to check in, see, does this person, they've been saying, yes, I'm ready, but, are they really at the point where they're ready to make that change? So you could say to somebody after you do the brief intervention, on a scale of 1 to 10, how ready are you to make a change? And no matter what number they say, you always want to say, what made you pick that number instead of a lower number? The reason that we're doing that is we really want this to be a conversation starter for more change talk. We're trying to always kind of have the person reiterating what changes they want to make and what is their motivation, because it's always about that internal drive for those changes. So just a little review with the brief intervention. You want to start with providing some feedback on the screening tool results. So after you screen, this is the chance where, you might say something like, is it okay if we talk about the results of the screening? And you want to give the person, some feedback. This was your score. This is what that score means. And then you want to ask them, how do you feel about that? You want to understand, are they shocked by the results? Are they not shocked by it? Is it upsetting to them? Understand a little bit about what that screening tool, it's there to give you an idea of their risk level. It's also there to be a tool for communication and for further discussion. So it's really important to not just do the screening tool and then move on, but really incorporate that into the next steps. And then you're always using those motivational interviewing skills. So your open-ended questions. What are some things that you like about using heroin? What are some things that are not so good about using heroin? Affirmations. That's great that you've been able to cut down from 20 cigarettes a day to 10 cigarettes a day. Those reflections we talked about. You have your simple reflections. There's also complex reflections, something like feelings or the double-sided. So you really want to use those reflections throughout this conversation. It's a nice break from the question and answer, especially after you've just done the audit, DAS, or TAPS. You want to have the chance to just have a normal conversation. We don't always endlessly ask our friends and family questions. We also incorporate, oh, that's terrible, or that's great, I'm so happy for you, I'm sorry to hear that. It's a normal conversation, and we want to show that it's a normal conversation. Summaries, as I mentioned, you just want to wrap up the visit, make sure they're on the same page, you're on the same page. You want to emphasize their reasons for making change, and also to remind them of some positive outcomes that can come from it. Obviously, these are the positive outcomes that they see. We have our own ideas about what happens if someone makes a change to their substance use, but it's really about what do they see that would be the benefit. And then again, always, recognizing and responding to both sustained talk and change talk. So sustained talk, somebody who's kind of like, I like what I'm doing, I want to stay here. You want to try and use those reflections, and you also want to emphasize their own choice to make those decisions. Change talk, you're listening for that darn cat. So the desire, ability, reasons, and need. This is them thinking about making a change. The commitment, action, and taking steps. And so for those two, you're also thinking, what are those reflections? What's an affirmation that I could give? Or how do I prompt some more change talk? And those could be those look back, look forward, asking about extremes. And so all of this part, you're really trying to figure out what is their readiness. So you have this conversation, you use all of your ORA skills, sort through sustained talk and change talk. And then, that might be a really great point to ask about readiness to change. Or sometimes people prefer to use an importance ruler. How important is it for you to make this change? Or how confident are you to make this change? So if you have a little more time, you could go through the 3 different rulers. If you don't, pick the one that seems to be the most important. If somebody is saying a lot of reasons why they have to make a change, then asking them about the importance might make sense. If you feel like somebody is has a lot of reasons, but maybe they're not the most confident person, maybe you want to ask about their confidence to make a change so that you can take the opportunity to remind them of other changes that they've made. So, and they don't have to be related to substance use. Somebody who struggled with taking their medications and then was able to take them every day is somebody who has that commitment, who really can follow through, who values, you know, taking their medications and, you know, trying to make healthy behavior changes. So you can use that as a motivation and as a reminder that this person has a lot more skills and strength than they realize. Motivational interviewing and SBIRT is really about, it's strength-based. We're trying to, you know, get people to see their own strengths that sometimes they don't see. And you may find with some of your patients who have been struggling with substance use for many years, you know, they may not have the best relationships with family. They may not have a support system. And so you are that support system, and you want to make sure that people feel like they can turn to you and that they also have that ability to make those changes. Okay, so the last part of SBIRT is referral to treatment. And there are so many different treatment options. I'm sure you're familiar with these. I'm just gonna kind of go over them quickly and some, you know, a couple points. So I know it's a lot of text there, but I'm sure you're familiar with many of these already. So the first one is individual counseling. You know, this is someone getting to work one-on-one with a counselor, psychiatrist, something else, and they can talk about a lot of different things. You know, what you may find is somebody using certain substances really is less about the substance and maybe as a way to cope, or maybe as a way to handle some, you know, relationship issues that they're having. Maybe this is actually about a psychiatric disorder. So there could be so many different reasons. It could also just be that, you know, there is a physical dependence and withdrawal can be miserable. And so some people, you know, may just be struggling with that. And so talking to someone one-on-one, really taking the time to sort through these things, you know, can really help someone. There's also group counseling. So this might be somebody going to groups at a clinic or at a day program, and starting to see different groups like anger management, relapse prevention, harm reduction, smoking cessation, lots of different options for it. Then there also are adult day treatment programs, depending on, you know, where you are and what, you know, resources your patients have access to. You know, this could be something really great for somebody who doesn't have a great support system. A lot of these, you know, centers provide meals, day trips. They have a lot of groups and one-on-one, and people really find a solid support network there. I'm going to talk about medication-assisted therapy in 1 minute. And then obviously you have detox, so this could be inpatient or outpatient. It's really to monitor withdrawal symptoms and understand that change is difficult, but change is very difficult when your body is going through withdrawals, and it's also dangerous. So somebody who is you know, doing detox from alcohol really needs to be in a medical facility, needs to be monitored, you know, for their safety. And then lastly, you have 28-day programs. So somebody may go from detox to a rehab, and this is where they're really doing individual and group therapy sessions. Gives them the opportunity to explore a little bit more than something than, you know, an outpatient setting might allow. There's also a lot of different treatment options that are not listed here, things like acupuncture, meditation, yoga. There are alternative treatment options, some of them depending on insurance and depending on, you know, the financial situation for that patient, they may or may not be able to access, but there are different options. And, you know, slowly these options are going to be covered or are slowly being covered by Medicaid and other insurance companies. So medication-assisted treatment, you know, some patients, just having counseling may not be enough. Also, there is, like I said, the physical withdrawal. So there are several medication treatment options for opioid addiction, including methadone and bupe. you may be at a center that actually your providers are prescribing bupe, and so it's something that you can take care of internally, or there may be this may be something that you have to refer out to. And then, of course, I'm sure you're all familiar with naloxone. So this is for opioid overdose. Depending on where you are, you may be able to even get that the naloxone kit for yourself. I know I've gone to a training and been able to get it. And so it's just something important for you to talk about with those patients who are using opioids, making sure someone in their family or friend group or somebody knows how to administer naloxone and has it. And that's something really important. Okay, and just some common mistakes to avoid. So, sometimes we get kind of ahead of the patients, and I know sometimes this would happen to me when I was a patient navigator or care coordinator. Sometimes, like, I was so ready to, schedule them to go to detox or get into a day program, and I did all the referral, and then, they weren't ready, and they didn't want to say no. They wanted to, they didn't want to say no. So I went ahead and I was kind of steps ahead of them. And then the referral wasn't successful. So there's a few ways you can, try to learn from that. So one is you don't rush into action. You make a treatment referral when the person is actually interested and they're ready to go. The other thing is really knowing your referral base. Depending on where you are, you might have a lot of resources or you might have very few. There may be a lot of options, so a lot of open beds. There may be very few, so long waiting lists. So it's important to know what's available. That way you can, give the patient a realistic idea of, what is possible. And as always, you really want to make a warm handoff. So this is, if you're doing an internal referral, understanding that you really want to build up that next person. This is my coworker, Peggy. She's been very good at helping some other patients, talk about things that are going on with them, or, other people felt she's really helpful when it comes to, tracking down resources and getting connected with somebody. Just you want to build that up. Or if you're making an external referral, try to know who's going to be answering that phone. If it's a small facility, know someone's name so you have a contact to call. If you can create linkages with those places, just to make it smoother for your patients, because the more barriers that are there, the harder it's going to be. So, there's things like, do they take their insurance? Is there transportation? If they have children, what are, child care issues while they're at a counseling or day programs or detox, things like that. And then it's really important to think about medications in support of the counseling and all those other things. So just making sure that, we're providing all the resources and everything that we have. And lastly, just keeping in mind that people, they're not resistant, they're not self-sabotaging, they're just not really at the place where you think that they should be. And so, this is thinking someone's in pre-contemplation. That's not a difficult person. That's somebody they're in pre-contemplation, and we've got to work with them in pre-contemplation. I went to a wonderful training at the Harm Reduction Coalition, and one of the trainers said, MI and harm reduction is about meeting someone where they are, but not leaving them there. So we're respecting that this is where they are, but we're also trying to figure out, what kind of changes can be made that they're interested in, that are feasible, and that might reduce some risk. So it might not be that you're talking to somebody who wants to quit a behavior, but maybe you just want to give some information about using their substance in a safer way. So it could be, talking to somebody who's using opioids and just making sure that naloxone is nearby. And that's where we are, and that's where we want to work from. Okay, so to recap with referral to treatment, there's a lot of different treatment options. I'm sure you're familiar with many, and just, as best you can, having a list of referrals in the area so that you can, quickly make referrals. Doing that warm handoff internally is so important. If possible, you want to introduce the patient to that next staff person, in person, or maybe by phone, just making it so it's a smoother transition. And then making sure that we're doing patient-centered planning. So this means that instead of telling a person, oh, you want to cut down on drinking, maybe you should stop drinking during the week and just drink on weekends. You could say, you're interested in cutting down on drinking. How would you like to do that? Let them guide it. They're going to tell you, because if you come up with a plan, some people may say yes because they're not somebody who wants to argue, and some people, you're going to get into a back and forth, and it's not like the best use of time. You really want them to figure out, do I want to make a change? What does that change look like, and how can I go about it in the best way? And then it's also really important to document the steps that you made for a referral. A key part of SBIRT is, I'm sure you're already having many conversations with your patients about substance use. It's understanding that, it's to document it. Making sure if you're using an EMR that you can document the audit, the DAS, the TAPs, referrals. Maybe your system can actually electronically record referrals, or a way for you to keep track of this. So it's making sure you're giving yourself credit for grant purposes, for billing purposes, and also just so that you have things to look at, and if there's a change in staff member, somebody knows where the other person left off. All of those reasons why it's so important to be able to document SBIRT in your system. Okay, so with SBIRT, the way that we kind of pull it all together, this is known as a brief negotiated interview, or BNI. And so what you're doing in this is, the first thing is build rapport. You need to have rapport, you need to have a good relationship, as the foundation before you move on. In the building rapport, you're doing, think back to screening, you're asking permission, you're normalizing the questions, and you're really making sure that people understand why you're asking these questions, and that this is a place to not be judged for it. Information and feedback, these are the screening results. Is it okay if we talk about them? Maybe you want to say something like, what do you know about the effects of drinking? They give you their answer. Is it okay if I give you a little bit more information? You give some information, and then say, what do you think about that new information? So you're not there to give advice, you're there to give information, and to give feedback and be supportive. And then the enhancing motivation, this is where we're really asking about the pros and cons of use, and figuring out, are they at the point where they're ready to make a change, and then lastly, what would that change actually look like? Okay, so you have a couple roles in the SBIRT process. I mentioned already, you're giving feedback, you're offering information. It's really key that you're trying to understand, what is happening from the patient's viewpoint, not from your viewpoint, not from a medical background viewpoint, but what is really happening with this person. And again, we're there to support the patient and explore their options. Make sure that they understand the different treatment options, and that there are different ways for them to make some changes. And then assist them in making new decisions, whether that's internal referrals, external referrals, or just making an appointment for them to come back and see you in a couple weeks or couple months, and kind of check in and see how things are going. Okay, so to wrap this all up, reminder, the screening, this is where you're using one of those validated screening tools to ask about alcohol, drugs, prescription drugs, and possibly tobacco use, using that MI approach to it, so ask permission and normalizing. The second part is, you're using motivational interviewing throughout this intervention. So those OR skills, looking for sustained talk and change talk. And the best advice that I can give with motivational interviewing is, it's very easy on paper, it's an easy concept, but when you're actually in front of the patient or the client, sometimes it's a little harder. So this is something, practice, practice, practice. That's the best way to, really improve your skills and feel comfortable. And it's something that honestly you could use with patients, you could use with family or friends. I don't think anyone's going to be upset if you are using affirmations. You know, who doesn't want to be acknowledged for hard work? Even if you ask your friends, you know, you probably ask a lot of open-ended questions already, but just using those as much as possible. And then really figuring out, you know, what is their readiness to make a change, you know, and work with them to develop a plan. And, you know, if needed, you make that referral. So thank you for going through this. I hope this gave you a brief overview of what SBIRT is. To really understand SBIRT, though, it's not so much about learning the concepts, it's about practicing it. So if you're interested in some more training on SBIRT, you know, you can reach out to one of your local AETCs and see about scheduling more in-depth trainings where it's more hands-on, you know, practice with the MI skills, practice going through the screening tools if this is something new at your site, and even, you know, doing some role plays that kind of let you do that brief negotiated interview. So thank you again, and I hope you have a good day.